So the first patient is a 31-year-old Caucasian woman who first presented to her primary care physician with intermittent myalgias and difficulties with taking care of her child and doing some of her activities of normal daily living, like cleaning a house. She did have a long-standing or relatively long-standing history of psoriasis, predominantly affecting her scalp, that was controlled with a shampoo. And a pertinent medical history component was that there was a question at one time as to whether or not she had multiple sclerosis. On physical examination by the PCP, the patient did have some tenderness, and this was somewhat diffuse, predominantly in the upper extremities, but also affecting the right knee. And she did have some swollen joints, including the PIPs of the right hand and the right shoulder. Importantly, since she had this questionable history of MS, her neurological exam was normal, but her examination was significant enough that she had difficulty with her motion, and the limitation of motion was predominantly due to the synovitis. Otherwise, her physical exam was essentially normal. And she had imaging that was done that did reveal asymmetric erosive changes in the small joints of the hands and some narrowing of the interphalangeal joints. So she fits very nicely, even with just that information, into a potential diagnosis of psoriatic arthritis. And her laboratory tests supported that. She did have an elevation in her SED rate and her CRP with a negative rheumatoid factor and an ANA that was likewise negative. So she easily fulfills the CASPAR classification criteria for psoriatic arthritis. And even though we're not supposed to use that for making a diagnosis, I think that that information does provide us with the most common manifestations of psoriatic arthritis. And as such, the diagnosis was essentially clinched. So what would be the therapeutic goals for this patient? It's interesting that there are studies on treat to target in psoriatic arthritis, but in clinical practice, there isn't an easy outcome measure that we can utilize for what I really call not psoriatic arthritis necessarily, but I call it psoriatic disease, because I think it's an umbrella of different components that impacts on your treatment choices. For example, many drugs are approved for psoriatic arthritis. Some tend to do better on the skin, for example, than on the joints, and we have the reverse as well.